What's up everyone, welcome back to my channel. In today's video, I'm going to be recapping the 2 rotations that I just completed in orthopedics. So if you're interested in ortho, if you want to hear about what I did these last 2 months, stay tuned. So starting with my schedule, I worked Monday through Friday, 8 to about 5:30 or 6 p.m., just depending on how many patients we had that day. I worked with everyone from our spine surgeon to our upper extremity surgeon. He did hands, elbows, shoulders only. Our hip and knee surgeon, and then a PA who was actually my brother. He wasn't my primary preceptor, but I got to work alongside my brother for a decent amount of time. This rotation was all outpatient clinic work. I really wanted to get into surgery, but the contract with my program and the hospital that the clinic was affiliated with never got pushed through in time, so I never actually got to get into surgery and get my hands dirty. I observed a few cases, but that was kind of a bummer. I didn't actually get to assist in surgery, so I spent a lot of time in the clinic, which was also good because I got to see so much ortho actually happening in front of me. The bad thing about PA school is that we are not taught ortho like we need to know for a future job if you're going into this field. You're taught enough to get you by on your board exam. I think it's 10% of the pants. But if you see your future being in orthopedics, do not expect what you learned in PA school to be near enough. For example, we didn't learn a thing about SI joint dysfunction in PA school, and when I was with the spine surgeon, I learned so much about it. I learned the 5-6 different physical exam provocative tests that you can do. I learned how to work it up. I learned that it's a diagnosis of exclusion. It requires a few diagnostic injections to actually prove if that is where the patient's pain is coming from. And at that point, if those 2 injections are positive or confirmatory, and you have a negative lumbar MRI, and you have failed 4 weeks of physical therapy, then the patient is a candidate for surgery. That is what's needed. That's what insurance requires. That's how a patient is worked up from their initial complaint until surgery. And did not learn any of that in PA school. And that's nothing against my program. According to the spine surgeon I was with, he said PAs don't learn about SI joint issues. Medical students don't learn it. Residents don't learn it. Even most orthopedic surgeons don't know about it. It's just a joint that's not very well known unless you're an orthopedic spine surgeon specifically. So that was really cool getting to learn all of that firsthand from a spine surgeon. And this guy's been doing his job for 70 years. I mean, he's 70, so technically he hasn't been working that long, but you know what I mean. One of the crazy things about ortho is that when you're in the clinic, you see a ton of patients. And I don't know if the clinic I was in was more than average or kind of at average, but we would see about 50 to 60 patients a day. If I was with one of the providers that they only had 40 to 45 patients that day, that was a pretty slow day. We were looking around like, we got a vacation today, you know? Only 45 patients, not bad. So you see a lot of patients. It's very fast paced. You're thrown into it right away. The good thing about that is you're seeing a ton of people, yes, but you're also seeing a lot of different orthopedic conditions. So you're also getting to learn so much more. Some of the things that I really liked about this rotation is that I was able to see all the new patients on my own. So if their chief complaint was shoulder pain, back pain, hip pain, leg pain, knee pain, whatever joint in their body that hurt, I would see them first, do my workup and my assessment and what I thought was going on, and then tell my preceptor kind of where my thought process was and what I thought the diagnosis was and what we should do. Another cool thing about this rotation, and it kind of made up for not being able to go into surgery, was all of the injections I got to do in practice. So I injected a ton of knees, a few shoulders, a couple of hips. Basically, going back to how PA school doesn't really teach you enough for the job that you'll have in orthopedics if you go into it. There are a lot of different formulations that you can use in an injection for, say, osteoarthritis of the knee. Of course, you almost always start with cortisone, but if over time the cortisone is no longer working or giving relief as long as it was previously, you can switch to viscosupplementation, which is hyaluronic acid, which people like to say is the rooster comb shots. So we had Synvisc, we had Durlane. There's also a longer lasting cortisone that you can give your patient called Zilretta. So as you can see, my first week in ortho, they're throwing around all these terms, Zilretta, Durlane, Synvisc. Just hearing these words, things that I'd never learned in PA school. Because this is a specialty, this is the first rotation that I've done in an actual specialty. It's upper level stuff. The knees we always injected for osteoarthritis. The hips, Those were for trochanteric bursitis if it was hip arthritis and they were needing an injection. We would set them up for basically an injection under x-ray. Subacromial injections or shoulder injections for rotator cuff tendonitis, we would do in the office as well. Again, if it needed to be intra-articular for arthritis actually in the shoulder joint itself, that would need to be done under x-ray, so we wouldn't do it in the office. The same can be said for the injections in the back for facet arthritis or epidurals, or the injections for the SI joint. Those are all done under x-ray. I'm really trying to think, and I don't know if there is a certain thing that I disliked about this rotation. The providers in this clinic, they all interpret their own x-rays and MRIs and CTs, and I'm still so early on that I haven't gotten that experience and feeling comfortable going over an MRI of, say, the lumbar spine or shoulder, or looking at even an x-ray of the lumbar spine and trying to diagnose what's going on. So it was more so not on the rotation itself, but just on me and my experience and where I'm at, not having that level of comfort and just being able to look at an image and putting that with the physical exam to diagnose a patient, because there were many times when I would come out of a patient's room and I would have a pretty good idea of what was going on, but I didn't exactly know what was going on in the image to be able to definitively diagnose that person. I could pinpoint one thing I didn't like about this rotation, and that was learning how to dictate. So dictation is whenever you have a microphone, and instead of typing your patient notes, you are speaking into the microphone, and the computer is translating your words into text on the screen. And when you start dictating, you're gonna be so bad at it. I was terrible. I would sound like a robot, I think. I would be like, 50-year-old male presents, and then stop, and then look down at the screen, make sure that what was there was correct. It was painful, I'll just put it that way. And I didn't speak too loudly because we sit around like a nurse's station, so all the providers are out there. So one of the first times I dictated, there's like 3 surgeons standing doing their dictations as well. So I'm like talking really quietly, hoping that no one hears me, hoping that I don't sound too stupid. But I did get better at it. I'm still not perfect. I still have a lot of work to do, but dictation is a difficult thing to master. It's awkward. You have to organize your thoughts and put them on paper, and it's just hard. You'll get through it if you have to dictate. You'll know what I'm talking about, but it's definitely a learning curve. So here are a few things that you need to know as a student if you're going to start an orthopedics rotation. Simply know your anatomy, of course. Obviously, orthopedics is 90% anatomy. Then I would take a step back and think of all the joints in the body, and then have at least a few things in the back of your mind, some diagnoses of what can go wrong with that joint. So for example, if we look at the shoulder, it could be arthritis, it could be a rotator cuff issue, it could be a slap lesion or a labral tear, it could be a biceps tendinopathy that's kind of manifesting as shoulder pain. And then once you have some of those diagnoses for a joint, then kind of think about how that is going to present and how you're going to diagnose it. So we always start with an x-ray, but then different physical exam maneuvers like the open and empty can tests, Hawkins test where you bend the arm in, and if they have pain in the shoulder, it increases your suspicion for a rotator cuff etiology. Speeds test, Jurgensen's test, these are all things to diagnose slap lesions or biceps tendinopathy. Kind of have a list ready and work from that. You're not gonna be perfect when you start the rotation. I definitely wasn't. I didn't know anything, honestly. I knew in the shoulder you could have rotator cuff problems, didn't know what a slap lesion was, had no idea what half of these physical exam tests were, and over time you hear about them again and again, and it helps solidify it. You see the patients again and again, and you just feel more comfortable, and after a few weeks you start to get the hang of things. So that's my best advice. Just come at it knowing a little bit about all the different joints in the body, and then as you do the rotation you'll be able to piece it together more and more. One of the other things that's hard about ortho, and that I didn't really realize until I started the rotation, is that your workup as a PA is dependent upon who your surgeons are. So like I said, we have a spine surgeon, we have a hand, elbow, and shoulder surgeon, and we have a hip and knee surgeon. They all want their patients worked up a certain way, and they all do things that's specific to them, and you might have the knee surgeon at your clinic that does things this way, but a knee surgeon at another clinic a mile down the road would do it totally differently. It's just dependent on what they like and what they want done. For example, in PA school, you learn that a scaphoid fracture gets you a thumb spica splint. That's pretty much all they teach you. At the clinic that I worked at, a scaphoid fracture gets you a thumb spica splint, yes, but it's a long arm cast for 9 weeks, and then you transition to a short arm cast for 6 weeks. That's literally so much time in a cast, and here I'm thinking that it's only a thumb spica splint. You know, you get that much more detail when you get onto the rotation, so that's just something to be aware of. I also enjoyed that I was able to see kids as young as 4, 5, 6 years old, all the way up to people in their 90s. So you see all ages of life, which is cool about ortho. You're not stuck seeing only 50, 60, 70-year-olds like you would maybe in internal medicine. All the providers in this clinic were also super approachable. Everyone is incredibly nice, very open to answer any questions I had, and trust me, I had a ton of them. So that wraps up this recap on ortho. Definitely one of, if not the best rotation that I've done so far, and it's really solidified my desire to go into ortho once I graduate and pass my board. So thank you guys so much for watching. If you haven't yet, please like and subscribe to my channel. I would greatly appreciate it. And I hope you all have a wonderful day.